Assalamu alaikum, everyone. This is Dan Almazroua. Today, inshallah, I will be discussing pancreatic disorders. We're going to discuss these topics. First, we're going to start with a brief review of anatomy and physiology. Then we're going to move to acute and chronic pancreatitis. Then we're going to see how we approach pancreatic masses. And then at the end, we're going to discuss the neuroendocrine tumors of the pancreas. So let's get started. First, we're going to discuss the anatomy of the pancreas. Let's look at the picture so that it's easier. First, we divide the pancreas into three parts. So we have the head of the pancreas, then the body, and then the tail. This makes studying the pancreas much easier. So we know that the pancreas is this organ that the head just lies in between the duodenum, so just the curve. So between the parts of the duodenum, this is the duodenum, we have the head of the pancreas, and then at the tail here, we're supposed to find the spleen. So this is where the pancreas is in the body, and you can see it in the abdomen here, in the epigastric area. It's a retroperitoneal organ, and that's an important information. In adults, it measures about 10 to 15 centimeters in length and weighs 60 to 150 grams. Okay, now there are certain important special things about the pancreas is that it has both endocrine and exocrine functions, meaning exocrine is basically if you remember from first year, the pancreas releases certain enzymes that are very important for digestion. So it releases things like lipases for fat digestion, amylases for carbs digestion, and trypsin for protein digestion. So all of these enzymes that are released from the pancreas, they're part of its exocrine function, as well as the ducts, the acinar cells, which are the cells that release these enzymes. It also has endocrine functions, and that's what we see in the islets of Langerhans. So these are cells that are dispersed within the pancreas, and each certain cell releases a specific hormone. So the alpha cell releases glucagon, beta cells release insulin, delta cells somatostatin, epsilon cells, they release ghrelin. So this is an important information, and we need to know that the endocrine portion of the pancreas is very small. It's only about 1 to 2% of the pancreas. As we mentioned, the exocrine portion releases the digestive enzymes from the acinar cells and also includes the ductules and the ducts. And yeah, and this is a very important information here, is that enzymes are made as inactive proenzymes that are stored in zymogen granules. Basically, what this is telling you, subhanAllah, it's a protective way of storing the enzymes inside of the pancreas is that they're not in their active forms. So a proenzyme is an enzyme that needs an activation. And usually these enzymes only get activated after they release into the duodenum. So if you look here, we have this pancreatic duct. This is where we're going to have the enzymes release, and then they're going to go through this duodenal papilla, and then they're going to be released here. And that's where the enzymes get activated normally, in normal circumstances. Now let's also review the anatomy here so that it's easier. Here we have the gallbladder, here we have the cystic duct, and then we have here the common bile duct, and then it joins the pancreatic duct, and then they empty into the second parts of the duodenum at the duodenal papilla. And here is basically the sphincter of Oddi. So it's important to know these terminologies because in certain pathologies, we need to know where the obstruction happens or where a certain disease happens. So we need to understand how they all join together and empty here. Yeah, so that's for the anatomy and the function. Because the pancreas lies deep in the abdomen, many pancreatic diseases remain undiagnosed for a long time, which can lead to significant morbidity and mortality. This is especially important in cases of pancreatic cancer. It usually presents very late and it's very deadly, and we're going to discuss that later in more details, inshallah. Now we're going to start by discussing congenital anomalies of the pancreas. So the first condition we're going to discuss is pancreas divisum. So basically, normally under normal circumstances, during embryology, we have both dorsal and ventral pancreatic ducts. Now, the dorsal duct drains most of the pancreas, and the ventral duct drains a lesser portion of the pancreas, mainly the head. In normal people, these two ducts fuse together, and then they empty into a major and a minor papilla. Now, why is that important? Because after they fuse, most of the secretions of the pancreas will end up emptying into the major papilla. So let me draw it for you so that it's easier and it makes more sense. So we have the dorsal duct. This is the dorsal. Okay, and then we're going to have also the ventral. They're not going to ask you in that much details, but I just wanted to make sense to you. and this is the ventral. Under normal conditions, these two should fuse and they will both end up draining into the major papilla, which is the bigger one. Let's make this smaller actually. And then there is the minor papilla, which is present in everyone, but يعني the amount of secretions drained here is much, much smaller. Now, if this fusion does not happen, the problem is this dorsal duct will start draining into the minor papilla and the ventral will start draining into the major. And I just told you that the dorsal drains the majority of the pancreas. So now you're stuck with the majority of secretions going into this very small opening. So it's like there's a functional obstruction. So the most of the pancreatic secretions start to build up, and this can cause like repetitive pancreatitis. Over time, the repetitive inflammation can cause fibrosis, strictures, and even progress to chronic pancreatitis. So that's why this condition is important to understand, because this can cause repetitive inflammation of the pancreas or repeated pancreatitis. And this is just a picture to show you the pancreas divism. I don't think they will ask you to diagnose from image only, but I added it for you because it was in one of your clinical lectures, so just so you can see it. Now we're going to discuss the annular pancreas. Now this condition is basically when part of the pancreas encircles the duodenum, as you can see here, and this can cause an obstruction. And imagine if instead of the pancreas being here and you just here, it goes all the way and encircles the second parts of the duodenum. This can cause abdominal distension, it can cause vomiting, all signs of like, intestinal obstruction. Other anomalies that can happen, agenesis, basically when the pancreas does not fully form. This is a very rare anomaly. Or ectopic pancreas, it's when the pancreas arises in a different place than the one we discussed. So we are going to see pancreatic tissues anywhere, but the sites that are most commonly we see ectopic pancreas as in are the stomach, duodenum, and then the jejunum. It's also not a very common condition, but you just need to know about it. Now, congenital cysts, they're generally unilocular, meaning they're just one of them, and they range from microscopic to 5 centimeters in diameter. They're never, or not never, they're almost never larger than that, so they're relatively small, and they contain a clear serous fluid. This is also important that the fluid is not mucinous, okay? And now we're going to discuss pancreatitis, and this is very important. From now on, the lecture gets more important. It's more important than the congenital anomalies, and this part will will repeat itself to you again when you're in 4th and 5th years, inshallah, during internal medicine rotation, surgery rotation. So it's very important to understand pancreatitis. So what is pancreatitis? Pancreatitis, as the name suggests, it is inflammation of the pancreas, and it has a very specific presentation. So it usually presents with epigastric pain that radiates to the back, and it can be classified into both acute and chronic. Now, the major difference between them is that acute pancreatitis is a reversible condition. So it's an inflammation of the pancreas, and then once the inflammation is gone, the pancreatic function is just back to normal. However, chronic pancreatitis, it's an irreversible condition because the pancreatic tissue basically is lost and the pancreas cannot keep doing its function. Now, this happens most commonly to either gallstones or due to heavy alcohol ingestion. Now we're going to start by discussing acute pancreatitis. Now, as I mentioned, it's a reversible inflammatory disorder, and of course, it ranges in severity. So it can be very, very severe with insane amount of complications, or it can be relatively milder. But either ways, we need to treat it immediately. So it can cause focal edema, fat necrosis, or it can spread and cause hemorrhagic parenchymal necrosis. So there is a spectrum for the inflammation. Now, approximately 80% of the cases are due to either biliary tract diseases or alcoholism. Now, let me explain this part here for you. Remember the anatomy picture? Let me go back to it here. Now, imagine if there is a problem in the biliary tract. Let's say there was a gallstone or a common bile duct stone that gets stuck here. Now, as you can imagine, if it gets stuck here, it can obstruct the pancreatic secretions. And if it does so, everything will start to build up. And then the pancreatic enzymes that we mentioned that they're supposed to get activated in the duodenum, they start to get prematurely activated within the pancreas. So the pancreas starts to autodigest itself, and this can cause inflammation or acute pancreatitis. So this is one of the reasons that can happen. It can be a gallstone. The other reason is alcohol. Now, alcohol is very toxic to us in our cells. So there are multiple ways by how alcohol can cause pancreatitis, and I'll mention them for you. So it's either because it's toxic to SNR cells, and I just told you the SNR cells are the cells that release the enzymes. So if it's toxic to the cells, this will cause the cells to release their enzymes. Additionally, it's been proposed that alcohol causes spasm of the sphincter of Oddi. So here, if you start getting spasm, you're basically blocking the drainage, and this can also cause pancreatitis due to obstruction. Now let's get back to the causes. So yeah, biliary tract diseases or alcoholism, these are the most common ones. Now, roughly 5% of patients with gallstones develop acute pancreatitis. So it's not like every person who gets gallstones will end up with pancreatitis, but you just need to know that it's a risk factor. Now, excessive alcohol intake has been reported as a cause of acute pancreatitis at variable rates. So it depends from one country to another how much it affects them. Ethanol or alcohol causes acute edema or spasm of the sphincter of Oddi, as I just mentioned, and stimulates secretions from the small intestine, and this can trigger the exocrine pancreas to release juice. Now, what causes pancreatitis? As I mentioned, the duct obstruction. This can cause an increase in intraductal pressure. Now, the pancreatic secretion starts to accumulate within the pancreas rather than draining into the duodenum. Now, it's very important here, this information, is that one of the enzymes that we find in the pancreas is lipase. So this is an enzyme that's usually not active inside the pancreas and gets activated in the duodenum. Now, what happens when it's activated prematurely is that it starts digesting fat. That's what lipase does from the name. It breaks down lipids. And this can cause fat necrosis. Now, why is that important? When lipases start to break down fat, they release fatty acids. When fatty acids are released, calcium starts to bind into them. And this can cause fat necrosis. When calcium deposit, this is what we call saponification of the pancreas. And this is a known complication. We're going to discuss that again, but I just want you to have this overview that this is caused by lipases. Now, there is a massive cytokine release and local inflammation and edema, impaired blood flow and vascular insufficiency because of the inflammation that is happening, and this can cause ischemic injury to SNR cells. There is also the primary SNR cell injury, as I mentioned, certain toxins, and this can include alcohol, certain drugs, even trauma, ischemia, infections. They can cause damage to the SNR cells. This will cause the proenzymes to accumulate, and then they get activated prematurely. Now, you need to understand that there is a cascade for activation. So normally, trypsin is the enzyme that gets activated, and it activates the other enzyme. So trypsin is usually stored as trypsinogen, and then in the duodenum, it gets activated to trypsin, and then it activates the rest of the enzymes. This is the cascade that normally happens, and normally it happens in the duodenum. If it happens within the pancreas, it starts activating all the other enzymes within the pancreas, causing pancreatitis. Another cause is defective intracellular transport of proenzymes. So normally proenzymes are packed alone, and lysosomal hydrolases are packed alone. Whenever they're packaged together due to defective intracellular transport, the lysosomal hydrolases, they're able to cleave trypsinogen to trypsin, and then trypsin activates all the other enzymes. So that's why they need to be packaged separately, and when they're packaged together, this can cause pancreatitis. Now, all of these pathways will end up doing the same thing. So proteases, they're going to damage the SNR cells, and this will start a vicious cycle. Lipases and phospholipases, this can cause the fat necrosis, as we just mentioned. Elastases, this will basically damage the blood vessels, causing hemorrhage, leakage of enzymes. Now, the activated enzymes will start to circulate freely into the blood because they're basically being released excessively because the pancreas is digesting itself. Now, this is important because in acute pancreatitis, you will always see the enzymes elevated. And this is a very, very important feature. We're going to discuss why later, but this is a feature of acute pancreatitis. These enzymes are always elevated. Now, this mnemonic here, I get smashed. It's very important. It's going to keep visiting you again and again for the causes of acute pancreatitis. So sometimes you don't know why the person gets acute pancreatitis, and that's idiopathic. Gallstones, we discussed them. Ethanol, we discussed them. Trauma, penetrating trauma especially, can also cause acute pancreatitis because it can damage the SNR cells. Steroids, viral infections such as mumps, autoimmune conditions, scorpion stings, hyperlipidemia, and hypercalcemia. Now, it's very important to remember that it's hypercalcemia. Calcium in nature activates a lot of enzymes, thus it can predispose to pancreatitis. Now, why did I say it's very important to remember that it's hyper? Because hyper is a cause, however, hypocalcemia is a complication. Remember how I told you when the fat is broken down and we release fatty acids, calcium can bind into them, and this can cause this saponification. Now, this mechanism is the exact same one that can possibly cause hypocalcemia. And when the person reaches the level where they have hypocalcemia, this is indicative of a poor prognosis. Now, endoscopic retrograde cholangiopancreatography, or ERCP, is also another cause because I don't know if you took it already, but it's an invasive procedure in which they go endoscopically, meaning from the mouth of the patient, and then they're basically inserting the device towards the pancreas. And this can complicate, this can have certain complications and cause pancreatitis. Certain drugs, as I mentioned, can cause pancreatitis, but you don't need to know them specifically. Now, this is basically very similar to what I just said, but I just want you to know that certain parasites have been associated with pancreatitis, such as Ascaris lumbricoides and Clonorchis sinensis. Now we're going to move on to hereditary pancreatitis. Now, hereditary pancreatitis, there are two specific genes that have been identified with that, and they're very important. So there's the PRSS1, and this is inherited in an autosomal dominant fashion. Now, basically, this PRSS1, whenever it's mutated, this causes trypsinogen to become very resistant to breakdown. It becomes hyperactive, and whenever trypsinogen is hyperactive and it's not breaking down, and it gets converted to trypsin, and it starts activating the other digestive enzyme, and this again starts the cascade that causes pancreatitis. The pancreas becomes prone to autodigestion and injury, and recurrent attacks of severe pancreatitis usually begin in childhood because it's a hereditary condition. So it's important to remember that this one is an autosomal dominance because the other mutation, which is this PINK1 mutation, it is actually a autosomal recessive mutation. And it's basically a mutation in the gene that is encoding a trypsin inhibitor. Normally, as a protective mechanism, trypsin gets inhibited by a trypsin inhibitor. Now, whenever there is a mutation in the gene that encodes for that, and you lose this function, this one here is a loss of function mutation, there is nothing to inhibit trypsin, and trypsin keeps being active, and this clearly predisposes to pancreatitis because you're not inhibiting the enzyme that is activating all the other autodigestive enzymes. Now, there are certain basic alterations that we see in pancreatitis. Now, it's an inflammatory condition, and with every inflammation, there are cytokines that are being released. There's lots of changes that happen to the blood vessels, and that's because of the cytokines. So they're causing vasodilation. The walls between the vessels become very loose. So microvascular leakage, and this can cause edema. Necrosis of the fat by lipases, which we discussed. It's an acute inflammatory reaction. There is a proteolytic destruction in the pancreatic parenchyma. Destruction of the blood vessels, this can cause interstitial hemorrhage. So there is hemorrhage within the interstitium of the pancreas itself. Now, as I mentioned, it's a spectrum. So basically, there are milder and more severe cases. In milder forms, the histological alterations include interstitial edema and focal areas of fat necrosis. The fat necrosis results from the enzymatic destruction of fat cells. As I mentioned, this happens by lipases. This is an important thing to remember. Just write it down for you. Excuse my handwriting. They release fatty acids. They combine with calcium, and then they're going to form insoluble salts that precipitate in cyto. Now, this is a pathology slide of acute pancreatitis. Now, what we can see clearly is that we can see lots of dilated blood vessels, and that is because it's an inflammation. So the cytokines that are being released will cause basically vasodilation. And we can also see lots of leukocytes here. So this indicates that there's an inflammation. Here we see the fat cells, which are always white under pathology. And this is likely indicating that there's saponification going on, which I just told you happens in acute pancreatitis. Now, macroscopically, this is what the pancreas would look like. So you're going to see areas of hemorrhage within the pancreas, along with a chalky white necrosis. So this is the fat necrosis that we're discussing, and that's the areas of hemorrhage within the pancreas itself. Now, the fat necrosis can be very extensive, that it involves fats even outside of the pancreas. So extrapancreatic fats, this can extend to the omentum, the bowel mesentery, and even outside the abdominal cavity, but that's in more severe cases. Now, how does a patient present? As I mentioned, there is a sharp epigastric pain that is radiating to the back. Usually, this pain improves when the patient leans forward. There is nausea, vomiting, as well as diarrhea because يعني the pancreas is needed and the enzymes of the pancreas are needed to digest the food properly, to be able to absorb it. So whenever you have this function impaired, even if temporarily due to acute pancreatitis, the patient can end up with diarrhea. Now, there are certain physical exam findings that we see in patients with pancreatitis. These are not specific, but if you see them along with the symptoms, they're highly suggestive for acute pancreatitis. So we have the Cullen sign, in which you see this bluish to purple discoloration around the umbilicus. And we also have the gray Turner sign, bluish or purplish discoloration again, but here it's in the flanks or the area between the ribs and the hips. So this area here. Now, the way I remember it is this is to the side, so as if someone is turning, so it's a gray turner. And this one is just the other one, which is Cullen sign. Now, how do we diagnose someone with acute pancreatitis? So we have three things that we look for, and you only need two of them or two of these criteria met in order for you to say this person has acute pancreatitis. So you need this the clinical picture, which is acute severe epigastric pain radiating to the back with nausea and vomiting. So this is the classical presentation of acute pancreatitis. So that's one criteria. The second one is elevated pancreatic enzymes. So you measure serum lipase or amylase, and they have to be 3 times or more the upper limit of normal. And this is important. If it's not 3 times or more, it's not meeting the criteria. It has to be 3 times or more. Another important information that can come in MCQs is that lipase is a more specific enzyme for pancreatitis as compared to amylase. Now, radiological evidence, we need to have imagings that are consistent with pancreatitis. Usually, we use CT scan to diagnose pancreatitis. So if any of these three, if two of these three are met, خلاص, you can diagnose this person with pancreatitis. So if these two are met, you don't need to do CT. That's basically what it's telling you. Now, how do we predict the severity of acute pancreatitis? I just told you that we have different severities in people. So there is a certain criteria that we usually use, which is called Ranson's criteria. Now, this criteria, we check on the patient twice. Upon admission or once the patient enters the hospital, and then we check during the first 48 hours of the patient's admission. So at admission, you're going to check the patient's age. If the patient's 55 years or older, this is a point. So it's a point system. So this gives him a point. If the WBC count is over 16,000, that's another point. If the blood glucose levels are high, this is another point. Now you might ask me why. Remember, I just said the pancreas releases insulin. So if the pancreas is not able to release insulin because of the inflammation, this is of course more severe than a pancreas in which insulin release is not effective. Now, lactic dehydrogenase over 350, AST levels over 250. So all of these can be checked upon admission, and if any of these are met, each one gives a point. Now, after 48 hours, we're going to check the hematocrit. If it falls greater than 10%, that's another point. We're going to check the BUN if it's more than 5 milligram per deciliter, arterial oxygen if it's below 60, serum calcium below 8. Remember when I told you hypocalcemia is considered a poor prognostic factor because of the saponification that happens when calcium starts to bind fatty acids. So that's where it meets us again. Base deficit that is greater than 4 milliequal per liter. Estimated fluid sequestration more than 6,000 milliliter. So basically that's Ranson's criteria, and I just added this here so you can see what happens at admission and after 48 hours. I just thought it's easier to view. And then this is basically how you predict the severity. If the score is 3 or more, this is considered severe. 3 to 4 has a mortality of 15%, 5 to 6, 40%, 7 to 8, it has a mortality of 100%. Now, I added these numbers because they were in your slides and I didn't want to miss on anything. I'm not sure if they would ask you, but just have a relative overview of the numbers if you don't want to memorize them one by one. Now, how do we diagnose? We always use CT scan if the criteria is not met, remember? So usually CT scan is what we go for in anything affecting the pancreas. If we look at the CT scan, so this is the pancreas, and around it you can see areas that are dark. This is showing you edema around the pancreas, which is what we see in acute pancreatitis, and also can indicate necrosis. So we usually do CTs to check for both pancreatitis and its complications. Now, how do you manage the patient who has acute pancreatitis? So supportive management, we're going to give the patient IV fluid, NPO and bowel rest. Basically, NPO is you don't give the patient anything per mouth. So you don't give them fluids or food by mouth. You stop that. You give them a bowel rest. Nutritional support, IV antibiotics are not always given. We give them in certain cases. So if there is any signs of infection, like if you see gas in the pancreas, this can indicate that certain microorganisms have infected the pancreas. That's when you give them antibiotics. So it's not really in every pancreatitis case. Percutaneous drainage of abscess if present. So if there is an abscess with the inflammation, we have to drain the abscess. Surgical debridement if needed. And don't forget the original cause. So if there is a gallstone, we need to remove that. We need to relieve the obstruction and so on. So we need to see what's the cause of this pancreatitis. If identified, you need to treat that cause. Now, what are the complications that can arise in someone who has acute pancreatitis? One of the most common complications is a pancreatic pseudocyst. Now, basically, it's a walled-off inflammation. And by walled off, I mean by fibrous tissue. This is very, very important. You need to understand that the wall of this pancreatic pseudocyst is not an epithelial lining, and this differentiates this cyst from other cysts. And that is why it's called a pseudocyst and not an actual cyst, because it does not have an epithelial lining. It is actually fibrous tissue that is lining the inflammation. It takes 6 weeks to fully develop, and this timing is very important. This can come in clinical scenarios as someone who had acute pancreatitis, and then after 6 weeks, he presents with whatever symptom, with whatever enzymes elevated. You should be suspecting a pseudocyst and order a CT to check for this pancreatic pseudocyst. It communicates with the pancreatic duct, as you can see here. Fluid content is usually rich with amylase. So on CT scan, this is what a pancreatic pseudocyst looks like. This is a very big one. But this is how you view it basically. And it accounts approximately 75% of all pancreatic cysts, so it's relatively common. It's a common sequelae of acute pancreatitis, so 50% of the patients are at risk after acute pancreatitis, especially those who developed pancreatitis due to their alcohol drinking habits. Now, if the patient's alcoholic and they develop acute pancreatitis, it's usually very clear in their history. So like regular drinking does not really cause acute pancreatitis. It's usually someone who's binging on alcohol, and they usually have had lots of, glasses of whiskey or whatever in the scenario before they present to you with this abdominal pain. So this is how usually it presents in scenarios. And in particular, alcoholic pancreatitis. Now, the cyst contents are rich in pancreatic enzymes, and a laboratory assessment of the cyst aspirate can be diagnostic. They can become secondarily infected, and larger pseudocysts can compress or even perforate into adjacent structures. I think this explains itself. You can just see in this pseudocyst, it is very rich in pancreatic enzyme, and we can aspire the fluid inside the cyst to diagnose it. It can also get infected, and because of its size, if it's larger, there's obviously high risk of perforation or compression on the adjacent structures. Now, other complications that can happen, with every inflammation, there is a risk of shock because there's a massive cytokine release. This increases the microvascular permeability and cause hypovolemia, and this can cause shock. Endotoxemia, it's because of similar concepts, so because of the cytokines, the barriers between the gastrointestinal tract and the bloodstream become very loose. So the GI flora can enter the bloodstream, and this can cause endotoxemia or toxins within the bloodstream. Renal failure due to acute tubular necrosis. I'm not sure if you took your renal block. I don't remember. You probably did. Acute tubular necrosis is basically a condition that happens whenever blood flow to the kidneys are reduced, and this can happen whenever there is a shock or a huge inflammation because the blood vessels get dilated, so blood flow to the kidneys becomes less. It can also happen due to certain toxins, but in this case, it's mostly due to the decreased blood flow to the kidneys. Now, what are the differential diagnoses of acute pancreatitis? So basically, you want to think of any pain that can happen in the epigastric area. So that would be a perforated peptic ulcer, biliary colic, acute cholecystitis that ruptured, occlusion of the mesenteric vessels with infarction of the bowel. So anything in the upper gastrointestinal tract can work as a differential. Now we have a question. I want you guys to pause the screen since this is recorded. Pause, try to solve, and then continue. So it's a 42-year-old man who presents to the clinic with epigastric pain radiating to the back. The patient has fever and lipase is elevated. So he has fever lipase elevated, epigastric pain to the back. This is very suggestive pancreatitis. Now, 6 weeks later, an important information, a follow-up CT scan shows a well-defined fluid collection around the pancreas with no epithelial tissues. What is the most likely diagnosis? That would be a pancreatic pseudocyst. So we had many keywords here. This is actually from your previous batch questions. So you can see how they specified the timing. They told you there is no epithelial tissue, very characteristic abdominal pain. So these are all telling you that it's a pancreatic pseudocyst. Now, another question is, a 42-year-old man presents with severe epigastric pain, radiating to the back, nausea and vomiting. Laboratory studies reveal elevated serum amylase and lipase levels. So basically, pancreatitis. A few days into hospitalization, his serum calcium level dropped significantly. What is the most likely cause of his hypocalcemia? So as I mentioned, it is saponification of fat in the pancreas. Whenever lipase starts to break down fat, it's going to be releasing fatty acids, and calcium can bind to them, and this causes hypocalcemia. Okay, so now we're going to move to chronic pancreatitis. So chronic pancreatitis, it's a long-standing inflammation in the pancreas leading to permanent damage to its exocrine and or endocrine functions. Now, chronic pancreatitis commonly happens due to repetitive inflammation of the pancreas. So whenever someone keeps having acute pancreatitis, like repeatedly, it will end up being chronic pancreatitis. Now, chronic is a very serious condition because the damage to the pancreas is irreversible. It loses its exocrine functions, and in more extensive cases, even goes to endocrine function, that the patient actually develops diabetes because the pancreas is no longer able to release insulin. Now, the damage, as I mentioned, it is irreversible. Most common cause worldwide is alcohol ingestion. So people who repeatedly binge drink, they end up with chronic pancreatitis because they will have repeated acute pancreatitis. Now, the second most common cause would be gallstones. Cystic fibrosis is the most common cause in children. That is in the case of chronic pancreatitis. Because cystic fibrosis, it causes very, very thick mucus secretions everywhere, so it can block the pancreas, and with time, this can lead to chronic pancreatitis. Now, another important information, I'm not sure if I didn't see it in your slides. I'm not sure if they would ask you, but a common cause of acute pancreatitis in children would be trauma. So just keep that in mind. I remember knowing this information when I was in third year, but I didn't find it in your slides. Anyway, other causes similar to acute pancreatitis, any other cause of chronic pancreatitis, it's idiopathic in 40% of the cases, which is a relatively high number. Now, what are the symptoms? Again, epigastric abdominal pain, steatorrhea, and that's because when the exocrine function of the pancreas is lost, there is no lipases, so you cannot really absorb fat, and then the fat will be released in stool, and this is basically causing steatorrhea. Insulin-dependent diabetes mellitus, because the exocrine function of the pancreas gets damaged first, and then eventually the endocrine will also be affected. The pancreas is no longer able to release or produce enough insulin, and this can cause diabetes. Nausea and vomiting. Now, manifests in several different ways: repeated bouts of jaundice, vague indigestion, persistent recurrent abdominal back pain, maybe entirely silent until the patient develops diabetes. Attacks can be precipitated by alcohol abuse. So as I told you, usually the scenario will specify someone who's binge drinking. They usually tell you the name of the drink. And just before he had this episode, he was drinking like insanely. So this is how the scenarios of pancreatitis are usually written in exams. Overeating, especially like fatty food, because it requires pancreatic secretions, or opiates or other drugs that increase the muscle tone of the sphincter of body. During an attack of abdominal pain, there may be mild fever and modest elevation of serum amylase. Now, a very important thing, remember how I told you in acute pancreatitis, we're always going to see the pancreatic enzymes elevated. That is not the case in chronic pancreatitis, because you see how the pancreas is actually destroyed in chronic pancreatitis irreversibly. Because of this amount of destruction, the enzymes are lost. The cells that usually produce them, they're destroyed. So basically, the enzymes may not be elevated in chronic pancreatitis. So we don't look for enzymes. Then what do? We usually go for a CT scan. Now, I put a star here because it was in your previous batch questions. So in chronic pancreatitis, in the CT, so this is the pancreas, you're going to see calcifications. And this is very, very important. And you're going to see it repeatedly. The CT scan will keep visiting you like in fourth year, in fifth year, in third year. So just know it. Whenever you see these calcifications in the pancreas, just know that it's a chronic pancreatitis. Now, if you do perform ARCP in someone with chronic pancreatitis, you're going to see the chain of flakes appearance. Basically, it's the pancreatic duct, and then you're going to see areas of dilation and then narrowing, and then dilation, narrowing, and then dilation, narrowing. And the reason is the pancreas becomes highly calcified, fibrotic. So the pancreatic duct will be compressed in certain areas, and then the area before it will be dilated. So it'll be narrowing and dilation, narrowing and dilation. So this is another characteristic finding on ARCP for chronic pancreatitis. Now, morphology. So grossly, the gland's going to be hard, sometimes extremely dilated ducts, and visible calcified concretions. And it's clear why. Microscopically, if you see these pictures, you can clearly see an extensive amount of fibrosis. And you can see the fibrosis everywhere. There is reduced number and size of acini, variable dilations of the pancreatic duct. Now, there is relative spalling of the islets of Langerhans, however. In more extensive cases, they will eventually also disappear, and that's when the endocrine function of the pancreas will be affected. Now, how do you manage chronic pancreatitis? The treatment depends on the presenting symptom. So, medical management, you can give them, if the patient has pain, you give them basic medications for the pain. If the patient developed diabetes, you need to give them insulin replacement. A digestive issue, you give them pancreatic enzyme replacement. Surgical, resection, drainage procedure. And that's like a type of surgery that can be done for chronic pancreatitis. Now we're going to move on to pancreatic masses or cysts. Now there is serous cystadenoma. So this is a very benign cyst of the pancreas, and it usually happens in the body or tail of the pancreas. The location here is very important. I will tell you why in a bit, but just remember, when we're discussing cysts, they're usually in the body and tail. Now, if you look under this histology image, you can see they're cuboidal cells, and this is also important, and it contains a clear or serous fluid. Usually happens in older age, has a female predominance. It's associated with von Hippel-Lindau or VHL tumor suppressor gene mutation. This is important, and it was in one of the previous exams. Generally speaking, all the genetic mutations in the pancreatic lectures are important. They ask about them a lot. Just try to remember all of them. VHL is seen in serous cystadenoma. Now we're going to move to mucinous cystic neoplasm. Now, 95% of the time, it arises in women. Again, it affects the body or tail. They're filled with thick mucin. And this is important because here we said it's a clear serous fluid. Here it is a thick mucin. Now here we see that there are columnar cells that are surrounding it. Here they were cuboidal. Up to 1/3 of these cysts can be associated with invasive adenocarcinoma and can progress to invasive adenocarcinoma. Now, the frequently mutated genes are KRAS, TP53, and RNF43. These are also important to remember, so I made them in red so you remember them. Now we're going to move to pancreatic cancer. In pancreatic cancer, incidence is higher in male. It's the fourth leading cause of cancer death in the United States. Pancreatic cancer is a very deadly cancer. Usually presents very late because it has very vague symptoms, very non-specific. And unfortunately, it's a very, very poor diagnosis for people. It's common in colored skin population. 80% of these tumors are metastatic at presentation, common in Jewish and Hawaiians, incidence 9 and per 100,000 patients, mean age of presentation 60 to 65, 5-year survival for all diagnosed patients, only 5%, median age developing the disease is 72 years. These are just information that are found in your slides, so I just had to mention them for you. They might or might not ask you, but I'm just going to keep them just in case. Now, you need to understand a concept in pancreatic cancer. And lots of cancers, actually, but in the context of pancreatic cancer, there's usually an accumulation of genetic changes, meaning there is a certain gene that gets mutated, and then with time, another gene gets mutated, and then with time, another gene gets mutated, and then the person develops cancer. So in the case of pancreatic cancer, you really need to know the sequence here. So usually it starts with a mutation in KRAS, and after there is a mutation in KRAS, becomes like the epithelium becomes dysplastic, just not insanely and severely dysplastic, just a little bit more dysplastic. And then if the patient acquires another mutation in P16, now P16 is a tumor suppressor gene. So if you inactivate that, you allow for more errors during the cell cycle, and this predisposes to mutations. So it becomes more dysplastic. And then there is a mutation in P53 or BRCA2 as well. And this basically becomes fully dysplastic, and then it can invade through the basement membrane and becomes invasive carcinoma. Now here, I'm just telling you that like mucinous neoplasm and mucinous cystic neoplasm, they all can progress to invasive adenocarcinoma. Pancreatic intraepithelial neoplasm, precancer lesion, they arise in small ductules. So this is the intraepithelial neoplasm, the one we discussed here. Before it invades the basement membrane, it is called intraepithelial, and it goes in stages. So there is 1A and 1B, and that's where basically we're going to have KRAS, and then 2, we're going to have P16, 3, that's P53, and then invasive carcinoma. Remember, 4 genes are most commonly affected by somatic mutations: KRAS, CDKN2A, P16, SMAD4, and CP53. Now, this is very important. I think this was in one of our SAQs. So you need to really memorize the genes and the sequence of them in case of pancreatitis. Now we're going to move on to other information. So Black and Native Americans are usually affected more than whites. Smoking doubles the risk of pancreatic cancer. There is a positive association between BMI and pancreatic cancer. This means whenever the BMI, the higher the BMI is, the higher the chance of developing pancreatic cancer. Diets rich in fruits, vegetables, fibers, and vitamin C, they're basically protective. Chronic pancreatitis and diabetes are associated with an increased risk, because anything that has repeated inflammation leading to chronic pancreatitis, it can predispose to pancreatic cancer. New onset diabetes in an elderly patient may be the first sign of this malignancy. That's why I told you it presents very late and usually very vague in its presentation. Familial clustering has also been reported. So because there's lots of genes here, you see, for example, BRCA2 mutation. So you see certain families that have BRCA2 mutation, the females develop breast cancer, and you see pancreatic cancer in this family as well. That's why there is familial clustering. Inherited predisposition to pancreatic cancer, there are certain syndromes like Booth-Jaeger. I believe these are things that you're going to study in other lectures. Hereditary pancreatitis, we discussed this already. Familial atypical multiple mole melanoma syndrome, all of these are syndromes that predispose to developing pancreatic cancer. There's no well-demonstrated link with coffee or alcohol consumption. Now, alcohol can cause chronic pancreatitis leading to pancreatic cancer, but there's no direct association between alcohol and pancreatic cancer without developing chronic pancreatitis. Now, morphologic. I'm sorry for the disruption. Let me just continue. My PowerPoint just lagged for a sec. I'm not sure why, but it's okay. Let me just go back here. Just want to make sure that it's recording. Yeah, it is still recording. Okay, perfect. Yeah, so morphologically, a gross presentation, gross morphology of the pancreas, it would be a hard gray-white, poorly defined mass. Mostly they're adenocarcinomas, so the type of cancer that we see in the pancreas, it is usually an adenocarcinoma. It is a highly invasive cancer, and there is a desmoplastic reaction. A desmoplastic reaction is basically the reaction of the surrounding cells to the cancer cell. So here you can see clearly a malignant cell. That's not a normal cell. And you can see surrounding it is what we see the desmoplastic reaction, meaning you see lots of fibroblasts, lymphocytes, and there are deposits of extracellular matrix surrounding it. Now, the symptoms, as I mentioned, they're vague and non-specific. So anorexia or loss of appetite, weight loss, back pain, jaundice, usually obstructive in nature with pale stool and dark urine. Now, this is very, very, very important. Why is that? Because pancreatic cancer usually arises at the head of the pancreas, most commonly, okay? So you can imagine, because let me just draw it for you so that it makes sense. Now, this is the duodenum. This is the pancreas, right? Excuse my drawing, but yani just imagine. And here you can see the drainage of the common bile duct, and here is like the pancreatic duct, and they're all draining together to the duodenum. If there is a mass here, it can compress on the common bile duct, and this can cause obstructive jaundice. Now, the obstructive jaundice is what causes the pale stool and the dark urine, as you've learned in your bile lectures for sure. So And because of the accumulation of bile, this can cause pruritus, skin excoriations, or scratching, loose malodorous stool because of the steatorrhea. There is fat malabsorption because the function of the pancreas is impaired, lipases are not released properly, and then there's exocrine insufficiency in proteases and lipases. Now, the certain symptoms, jaundice happens in 75% of the cases, weight loss in 51%, abdominal pain 39, nausea vomiting 13, pruritus 11, fever 3, GI bleeding 1. This is just for you to know that like the presentation is variable. Not everyone presents with all symptoms, but you just need to keep them in mind. So if someone presents with them, you can tell that, okay, this might be pancreatic cancer. Now, there are certain clinical features that we see. So migratory superficial thrombophlebitis or Trousseau sign, which is here in this picture, it is basically inflammation of the superficial blood vessels, and it's very characteristic or suggestive of pancreatic cancer because of the procoagulant state, that is associated with the, did I say state? I just meant to say state. Procoagulant state in any cancer, especially pancreatic. So remember that this is associated with pancreatic cancer. Now, there is also ascites that can be associated with the left supraclavicular lymph node involvement or Virchow's node. We can see it here. It is also characteristically involved. There can also be metastasis at the rectovesicle or rectovesicle in males, rectovesicle in females, pouch, or the plumber's shelf, hepatomegaly due to heart secondary nodules, mass in the epigastric regions, and cystadenocarcinoma. And because you can see how like the pancreas is very close to the spleen, and as I mentioned, it's a procoagulant state with lots of inflammation going on. This can inflame this splenic vein, causing splenic vein thrombosis, and this can cause splenomegaly because the spleen is not draining blood through its vein, so it will be enlarged. Now, as I mentioned, the most commonly it affects the head of the pancreas, and this is the most common site for pancreatic cancer. A very important sign that is very suggestive of pancreatic cancer is curvaceous. Okay, you have to excuse me for a sec because the pronunciation of this is actually very difficult. Curvaceous sign. This is basically a painless enlarged gallbladder with jaundice. So whenever someone is performing a physical exam and they sense that the gallbladder is enlarged, but the patient does not feel any pain, they don't report any pain, and there's associated jaundice, this is highly suggestive of pancreatic cancer. Now, because other causes of this obstruction that causes enlarged gallbladder, they're usually painful, like a gallstone, it would be painful. If it's not painful, then it suggests pancreatic cancer. Now, metastatic diseases, it can present with ascites, hepatic mass, hepatosplenomegaly, and the left supraclavicular lymph node that we mentioned. And there is also the Sister Mary Joseph nodule, which is metastatic umbilical node. The body or the tail cancer, they're less common, but they're usually very advanced and they're very silent, presenting very, very late. Now, pancreatic cancer, it can have a local spread to the adjacent structures, such as the duodenum, the portal vein, spuromesenteric vein, retroperitoneum. Cancers at the head of the pancreas have more tendency to spread. The spread is related to the tumor size. So the larger the tumor, the more likely it is to spread, especially if it's greater than 3 centimeters. Perineural spread is also common, meaning spread around the nerves. Sorry, guys, I'm just charging my laptop. Okay. Now, nodal spread, there's the perihepatic nodes, the duodenum, the common bile duct, subpyloric nodes, celiac nodes. So all of these nodes, we can have spread to them. Now, the nodes will be hard and usually dark in color whenever they're spread to them. Distant spread mainly to the liver. It can affect both lobes, and it's usually small. Occasionally, it can go to the lungs, adrenals, brains, and bone. Now, what are the investigations and what do we see in them? So we can order a liver function test. Now, the direct serum bilirubin will be elevated, and it's very important to remember that it's the direct because it's an obstructive lesion. That's why it's elevated. The direct one, I mean. And the serum alkaline phosphatase will be elevated. Serum albumin can be low because it can metastasize to the liver. So this is not always the case, but it's a possibility that we see the albumin levels low. And then there's the prolonged clotting profile because the liver also synthesizes the clotting factors. So if the liver is involved, the clotting profile will be prolonged because it's not making or synthesizing enough clotting factors. Now, the abdominal ultrasound is usually the first line testing. So if the patient presents to you with these vague symptoms, vague abdominal pain. Usually, you're just going to go with an ultrasound to decide. What they can see on ultrasound is that dilated gallbladder, lymph node enlargement, hepatomegaly, portal vein thrombosis, dilated common bile duct ascites. And you do not necessarily see all of these, but these are things that can indicate that there's a pancreatic cancer going on. Now, a barium meal, it's a historically used method, but it was in your slide, so I'm just adding it. So basically, the patient drinks barium and then they take images of his gastrointestinal tract. It can show widening of the C lobe of the duodenum. Basically, you can imagine if there is a pancreatic mass, it starts pushing on the duodenum, so it appears larger or widened. And that's what we call the reverse 3 sign. It suggests a periampullary carcinoma caused by external compression of the duodenum, such as the pancreatic head. It's rarely used now. It's a historical thing, but it was in your slides. What matters to us is a spiral CT. This is the most important. It tells you the size. It tells you if there is any venous involvement. It shows you the retroperitoneal lymph node to see if they're involved as well. And it determines the resectability, meaning if we can resect the tumor or if we can perform a surgery and remove this tumor or not. And this is a CT scan showing you pancreatic cancer. This is just to remind you that CTs are very important in the case of pancreatic cancer. Now, we can also do ERCP. When we do ERCP, you reach basically into the pancreas. So you go from the duodenum and you can enter through the sphincter of Oddi. You can do pancreatic juice cytology, brush biopsy, and these are advantages, of course, because you're able to actually take a biopsy from the lesion. Now, it can be used therapeutically as well. So this is important, even if the tumor is not resectable, like if you saw on CT scan that it's not resectable and the patient has jaundice, part of the palliative treatment is to actually do an ERCP and relieve the obstruction so that it lessens the jaundice. So ERCP will be used even if the tumor is not resectable, so you can relieve the obstruction. MRCP is just to outline the entire biliary tree and the ampulla. Now, a very, very, very important tumor marker is CA19-9. Please do not forget this one. It's very important. It comes very often. طبعا you cannot use a tumor marker to diagnose. I hope you know that by now. We usually only use them to monitor the patient's response to treatment, to monitor recurrence, and so on. And it's usually just supportive. It does not diagnose on its own. So let's say someone has pancreatic cancer and we identified that. We're still going to measure their CA19-9 so we can see if it's like it goes down after treatment or does it go back up again? This is what we're trying to monitor. Like after we have confirmed the diagnosis, it can either support our diagnosis if we're suspecting, but the levels of it, they're supposed to go down after we treat, and they're not supposed to go up again. And this can tell you that the tumor is recurring. That's what we usually use the tumor markers for. It's also not specific. It can be elevated in cholangitis or pancreatitis, and that's why I just told you it does not really diagnose. It's just supportive, and we use it to monitor the response and detect any recurrence. Now, there's another tumor marker, CA494. It's just can help you differentiate between pancreatic cancer from chronic pancreatitis. Carcinoembryonic antigen helps in differentiating pancreatic cystadenocarcinoma. Basically, within the pancreatic cystadenocarcinoma, if you aspirate the fluid, the CEA levels can be elevated, but they can also be elevated in pancreatic cancer. This is just to differentiate between like serous cyst and pancreatic cystadenocarcinoma. And serous cyst CEA will not be high, but it will be elevated in cystadenocarcinoma. But this can be elevated in lots of gastrointestinal cancer. So the most important one really is CA19-9. Okay. Now, moving on, other investigations that can also be ordered are endoscopic ultrasound with fine needle aspiration. This is a very, very sensitive screening modality or investigation. We don't really use it for screening, but I mean, it's an investigation modality. It's very sensitive to detect small tumors, even if they're not showing on CT, allows for fine needle aspiration so you can confirm histologically. It also assesses if there is any vascular involvement in the hepatic artery, superior mesenteric vein, portal vein, and enables the transduodenal needle biopsy. So that's a good thing. We can biopsy as well because we're going inside. That's endoscopic. Now, percutaneous transhepatic cholangiography. Here, basically, you insert a needle. You go inside through a needle. Now, this is helpful because you can drain. So before going into the operation, you can do biliary drainage with this one. It's usually done when ERCP is not possible. Now, you might ask, when would ERCP not be possible? So if the tumor is very, very large, that it's completely obstructing the duodenum, you can't even undergo ERCP to enter the sphincter of Oddi. We can do PTC instead of ERCP. Now we can treat it surgically. If the tumor is in the head of the pancreas, there is a certain procedure that can be done, and that's called Whipple procedure or pancreatico-duodenectomy. This is only for resectable adenocarcinomas of the head. We will discuss the resectability in a bit, but just keep in mind, if it's resectable, we can do the surgery. Now, with this surgery, I highly recommend that you write it in YouTube. Just write Whipple procedure, and you're going to find a video by Johns Hopkins Hospital. It has a perfect representation of it, like animations showing you how it's done. I think no matter how much I explain, without the animation, it's more difficult. I'll try to make it easier, but trust me, it's not very difficult. It just seems like a lot of words. Once you visualize it, if you open the John Hopkins video, it'll be very, very easy, inshallah. So I highly recommend you watch that video. So basically, in this Whipple procedure, they're resecting lots of things. So they resect the head of the pancreas, because this is where the problem is. This is where the cancer is. They're going to take the duodenum because it's stuck to it. So here, the duodenum is taken out, the head of the pancreas. They're also the distal common bile duct. So here it's the common bile duct. The distant portion here is removed. They also can remove the gallbladder. So the gallbladder will be removed. We don't need it at this point. Anything that can have, cancer cells, we remove it. Distal stomach or the antrum of the stomach in a classic Whipple is also removed. Proximal jejunum is removed and we keep the distal jejunum only. Regional lymph nodes will also be removed. These are mostly the portohepatic and peripancreatic lymph nodes. Now the reconstruction, meaning after we remove all of that, we need to attach the organs to each other. Because if you remove the duodenum, you can't leave the stomach floating and the jejunum floating. So you have to attach them. So you're going to attach the stomach to the jejunum, and that's what we call the gastrojejunostomy. And we also need to attach the pancreas, the rest of the pancreas, because we removed the head. Also, we're going to attach it to the jejunum because we removed the duodenum, remember? So we're going to attach them, and that's what we call the pancreatico-jejunostomy. And then this common bile duct will also be attached to the jejunum, and that's what we call the choledochojejunostomy or hepatico-jejunostomy. It's you can use these words interchangeably in Whipple procedure. Now there are certain like surgeries that can be done. So pylorus preserving, see here, when you remove the antrum of the stomach, you also remove the pylorus of the stomach, and that's not good. This increases the risk of dumping syndrome that I'm sure you discussed in your other GI lectures. So the contents of the stomach are immediately spelled here. So to lessen that, we keep the pylorus, and that's what we call pylorus preserving pancreaticoduodenectomy. So the pylorus and most of the stomach are preserved. The duodenum is divided about 2 centimeters, the still to the pylorus. So that's the difference. Now, an extended Whipple, this is done whenever there is involvement of the veins. There is a more aggressive lymph node dissection, include resection of segments of the mesenteric vein or portal vein if they're involved. Or sometimes it's done if we're avoiding post-Whipple's complication. Mortality is higher, and it can cause diabetes as well. Now, resectability. So what decides whether or not the tumor is resectable? So an absence of abdominal metastasis means no, it's resectable because we only have one tumor in one place. If it's metastasized, you can't really resect them all. No invasion of solid organs like the liver. No major vascular invasion. So the more there's an invasion, the less it is resectable. So patients with the cancer of the body or the tail of the pancreas and those with a CA19-9 that is greater than 400 nanograms, they have an increased risk for unresectability. It's just another information to keep in mind what is resectable and what is not. Now we're moving to the last part of our lecture, which is the neuroendocrine tumors of the pancreas. Guys, by the way, before I move on to this part of the lecture, I tried my best to focus on the high yields and what they might ask you in your final exam because I know your exam is very soon and I didn't want the session to be very long before your final. So if there is a certain point in your slides that I didn't really fully cover or you didn't really understand and you still want me to explain, and feel free to email me and I will definitely explain it to you. I'm just trying to make the session not too long so you all can use it before your final exam. Okay, now let's move on to the neuroendocrine tumors of the pancreas. Now, generally speaking, discussing like an overall features of the neuroendocrine tumors, they're usually associated with MEN syndromes or multiple endocrine. Actually, I forgot what MEN stands for. Imagine. I don't remember the last time I said what it stands for. Oh, multiple endocrine neoplasia. Yeah. Multiple endocrine neoplasia syndrome type 1, Werner syndromes. So type 1 is usually characterized by parathyroid adenoma, pituitary adenoma, and pancreatic tumors. So the 3 Ps. These commonly occur in the body and the tail of the pancreas. They're usually multiple and small. 30 to 50% of them are malignant. Now, the diagnostic methods that can be used are MRI, angiogram, and PET scans. Incidence are 5 per 100,000. Normal islet cells are less than 2% of the pancreatic mass. We already discussed that at the beginning. 20% of these are non-functional. Now, insulinomas are commonly benign. So if someone has insulinoma, they're rarely ever malignant. In contrast, glucagonomas are almost always malignant. Now let's start with insulinoma. So it's the most common one. 60% of them are arising from beta cells because we know beta cells of the pancreas are the ones that release insulin, secretes insulin, and imagine insulin is the hormone that is released whenever our blood glucose levels are high. So it lowers our blood glucose. Now, if it's released excessively and with no reason, this will cause hypoglycemia. So it's lowering blood glucose without even it being high from the beginning. So this will cause hypoglycemia. It affects males and females equally. In 90% of the cases, it's greater than 2 centimeters in size. 85% of the time, it is benign, so it is rarely malignant. Now, the symptoms are abdominal discomfort, weight gain, because remember, insulin is an anabolic hormone, so it can cause weight gain. Signs of hypoglycemia. Now, what are the signs? There's palpitations, tremors, sweating. All these are signs of hypoglycemia. And there might be behavioral changes as well because glucose is the main, it's the main food for your brain. So if the brain does not really get glucose, it can actually reach to a point where their behavior changes. It affects the brain that much. Now, these are all the things that we discussed in a table, but let me just discuss the diagnostic tests because they were not there. Now, monitored fast, it's basically when you ask the patient to fast and you monitor them, meaning you check if the patient is fasting, their insulin levels are supposed to go down. Now, if you leave the patient fasting and their glucose goes down, but their insulin does not go down, this is very suggestive of insulinoma. Insulin to glucose ratio, it's an older test, but it has the same concept. When glucose levels are low, you're expecting the insulin levels to be low as well. If glucose goes down, but insulin does not, this also suggests insulinoma. Anatomic localization evenly spread throughout the pancreas. Now, gastrinomas. Gastrinomas are arising from non-beta cells, the G cells, and this is easy to remember. So gastrin, G. It secretes high levels of gastrin, and this can cause Zelander-Ellison syndrome, which is a severe acid hypersecretion. We're going to discuss it again at the end. It's a commonest endocrine tumor associated with Menion syndrome. It is common in males. It's seen in gastrinoma triangle, Basara's triangle, pancreas, or duodenum, usually multiple, and 50% of the time it's malignant. Now let's discuss what the normal function of gastrin is to begin with. Now gastrin, when released, it stimulates the stomach to release its acid. So imagine if it's excessively released due to a tumor, like a gastrinoma, if it's continuously stimulating the stomach to release acid. This is really bad. This can cause ulcers in the duodenum, حتى even distal, it can reach the jejunum because there's excessive acid release. Also, the gastric mucosa will become very thickened because of the amount of acid it is releasing. So basically, that's what gastrinomas do. And usually they arise in this triangle, Pissar's triangle, which is basically, it's bounded by the cystic duct or the common bile duct or the junction between them here. And then the second and third part of the duodenum, and then the neck and the body of the pancreas. So that's the triangle. Also commonly in the pancreas or duodenum. So in the pancreas, you can see the gastrinoma, and the duodenum, you can see the gastrinoma. That's where they usually are. Now, what are the investigations? There's supposed to be an A here. So gastrin assay, gastroscopy, which is basically a scope to see the stomach, and you're mostly going to see thickening of the gastric folds. Endosonography, similar concept. MRI or CT scan, so you can see where the tumor is. Angiogram, because this tumor, it has lots of blood supply, so angiogram can tell you there's excessive blood supply going there. Calcium provocation test, which increases gastrin levels. So normally, calcium does not really affect the gastrin, but in gastrinomas, if you give them calcium, their gastrin levels will go up insanely. Now, the most important test here, if you're going to remember one test, it should be the secretin provocation test. Now, secretin, normally, if you give it to a normal person, gastrin levels would go down. In gastrinoma, the exact opposite happen. When you give them secretin, their gastrin levels goes up. And that's very, very, subhanAllah, it's very unique and very suggestive of gastrinomas. And this, again, this test will visit you again and again during step 1, during rotations. So it's a very important test for gastrinomas. Now, how do you treat it? Now, as I mentioned, this causes recurrent ulcers. So with ulcers, you're going to see lots of bleeding. So this can cause anemia, particularly iron deficiency. It can cause protein and amino acid deficiency. Again, due to the ulcers, prevention of DVT, it's a hypercoagulable state, so you need to prevent DVT as well. Distal pancreatectomy occasionally might require total pancreatectomy, but this is less common. Dacarbazine, it's a chemotherapeutic agent that can basically destroy the cells that are releasing the gastrin. Now let's discuss Langer-Elson syndrome. So this is the syndrome that I told you there are gastrinomas, and there is also ulcers in the duodenum and in the jejunum. So serum gastrin levels in the blood will be 10 times the normal. Basal acid output is going to be very, very high, more than 15 millimole per hour. The treatment is basically to remove the tumor, and you need to give the patient PPIs because gastrin stimulates the stomach to release acid. So you want to lower the amount of acid release as much as possible, and you give the patient PPI, or you can give them histamine receptor antagonist as well. In very extreme conditions, they actually need to remove the stomach or total gastrectomy because the stomach is the one that is releasing the acid. Now, there are two causes. It can either be a gastrinoma, which is what we just discussed, and it's the most common cause actually, which is a gastrin-secreting neuroendocrine tumor, or it can be a proliferation of the G cells, leading to hypergastrinemia. طبعا this is very uncommon, but it was in your slides. And when the G cells undergo hyperplasia, can be seen in men 1 as well. This can cause increased gastrin release. Now we're going to move to the other tumor, which is vipoma. Now, vipoma, there is an excessive secretion of vasoactive intestinal peptide, again, arising from non-beta cells of the pancreas. Now, 70% of the time, it is malignant, so it's a high percentage. Common in the body and the tail, it's usually solitary. The clinical features are usually WDHA syndrome. WDHA is basically watery diarrhea because vasoactive intestinal peptide stimulates lots of secretions to undergo. So it's going to cause watery diarrhea, hypokalemia because of the diarrhea. Basically, you're losing potassium, achlorhydria, dehydration, flushing, hypotension. This can also be known as pancreatic cholera or Werner-Morrison syndrome. Now, you can give them prednisolone to control the diarrhea, and octreotide is useful in cases of diarrhea and flushing. So octreotide basically decreases the amount of the hormone that is being released. So this can be given in vipoma as well. This is basically what I just discussed, but in a table. Now, glucagonoma, it's arising from the alpha cells of the pancreas, again, on the body and tail, most commonly in females. 20% of the time, it is associated with MEN1 syndrome. The reason I wrote this in red is because in your lectures, it says MEN2, but this is wrong. It's actually MEN1, it's not MEN2. 80% of the time, it is malignant, so that's, again, a very high percentage. It commonly spreads to the liver at the time of diagnosis. Now, just think about what glucagon normally does. So glucagon normally increases the blood glucose levels, increases the breakdown of lipids to synthesize glucose, promotes protein breakdown. Why is that? Because it wants to synthesize glucose. That's what glucagon wants. So it breaks down protein in order to synthesize glucose. So imagine the effects that are going to be on the patient. And the patient will be in a very catabolic state because it's breaking down everything, breaking down the fat, breaking down the protein, because it wants to synthesize glucose. This will cause weight loss. It can cause diabetes because the glucose levels are constantly high, amino acid deficiency because all the amino acids are being used to synthesize glucose. Of course, this is really bad. Now, there are certain clinical features associated with the glucagonoma that are very distinctive. So there is what is known as necrolytic migratory erythema. You can Google this and you're going to find lots of pictures. I didn't want to add them because the pictures, they're very painful to see. So if you don't want to see them, don't. But it's a very characteristic skin condition that is associated with the glucagonoma. It's a skin rash with a red blistering migratory lesion. There can also be mild diabetes due to hyperglycemia from the excess glucagon. But the diabetes here is mild because there are other hormones that are influencing the blood glucose levels. Diarrhea and weight loss from malnutrition and catabolism. Stomatitis and glossitis is also very characteristically seen. Anemia and decreased amino acids and vulvovaginitis. All of these are features that can be seen with glucagonoma. How do you investigate? MRI, CT scan to locate the tumor, endosonography, or, basically just again to visualize the tumor. Angiogram, same concept, blood flow increases to the tumor, so you can see that, and increase serum glucagon levels. This is again what I just discussed. just on a table. Now there is a WHO classification of the neuroendocrine tumors. Now, they can be benign or uncertain. Now, benign behavior is when they're confined to the pancreas and they're less than 2 centimeters in diameter, 2 or more mitoses per 10 high power field. This is يعني, seen in like pathological slides. I mean, the slides that are sent to the pathology. Then 2% or less Ki-67 positive cells with no vascular invasion or no perineural invasion. So these are all things that are seen in the pathology slides. Now, the uncertain behavior is when they go to the pancreas and one or more of the following features. If they're 2 centimeters or more than 2 mitoses, and more than 2. So basically the opposite of these. If they're more, it's considered an uncertain behavior. Now let's discuss MEN syndromes in more detail. So they're inherited conditions in an autosomal dominant fashion. They can cause tumors, hyperplasia, overactivity in multiple endocrine glands. So MEN1 is the 3Ps. It's also known as Wermer syndrome. So there is the parathyroid tumors, pancreatic neuroendocrine tumors, and pituitary tumors. Now, MEN2 can be subclassified into MEN2A and MEN2B. MEN2A and B both are associated with medullary thyroid carcinoma and pheochromocytoma. The difference is in the third. So if there is parathyroid hyperplasia, this is MEN2A. If there is mucosal neuroma and marfanoid habitus, this is usually MEN2B. Now, the last thing we're going to discuss is nesidioblastosis. This is basically, it's not a tumor. It's not like insulinoma where there's an actual tumor. It's just beta cell hypertrophy and islet cell hyperplasia. This basically causes excessive insulin release, but without an actual tumor, yani discrete tumor that is seen. This can also be due to ectopic islet tissues, multilobulated islets, ductulo-insular complexes. These are usually seen histologically. Now, when can you see this condition? Yani most commonly, this is seen in infants. So infants that are born to diabetic mothers, they're usually exposed to an insane amount of glucose. SubhanAllah, as a reaction, the baby's beta cells, they undergo hypertrophy to be able to release more insulin. So when they're born, they're going to have hypoglycemia because they're no longer exposed to the insane amount of glucose from the mom, but they still have this beta cell hypertrophy. That's when you can possibly see nesidioblastosis. But other than that, it's very uncommon, يعني, other than the newborns to diabetic mothers. Now, please scan the QR code for feedback. And thank you for attending the session. Again, if you have any questions or if there's anything that I did not really cover, I try to focus on what's important because I know your final is so soon. If there's anything more you'd like me to cover for you, feel free to contact me on my email, or if you have my phone number, feel free to text me as well. And best of luck on your final. Thank you for watching and have a great day.